Well, good afternoon. As I said, my name is Phyllis Arthur. I'm actually the Vice President of Infectious Diseases and Emerging Science Policy at BIO, a trade association based in DC. We're very happy to be working with a group of wonderful nurses and physicians to bring together this educational panel for the nursing community on the COVID-19 vaccines. Thank you so much for joining us. We know that reproductive health and women's health and fertility have been key questions that have been at the center for many women who are thinking about getting the COVID-19 vaccines. And so we wanted to actually share some excellent information from a group of esteemed thought leaders in the nursing and physician community with all of you in a very straightforward and simple to understand session. We're very excited to bring you information that's based on science and evidence, and hopefully it can answer a lot of the questions that many of you have, or for those of you who represent organizations, that many of you would like to be sharing with your constituents. We want to really take the day today to separate fact from fiction and bring you some of the latest research and guidance from key trusted partners. So today we're going to have 4 really wonderful speakers. Please know that while you are all muted, the question and answer function is already enabled. So as you hear the speakers do their presentations and there's questions, feel free to type them into the chat. We have about 10 minutes left at the end of the four presentations for questions, and I'll be moderating those at the end and reading them off. In addition, please know that the session is being recorded, and we will be posting it as quickly as we can to the BIO website, and we'll make sure to get that information out for you to share with people as soon as we can. We'll make sure to get people alerted so people can watch this. So many of you are working, or some of your constituents are working right now to help people. So let me start by introducing our first speaker, Dr. Grace Lee. Dr. Lee chairs the Centers for Disease Control and Prevention's Advisory Committee on Immunization Practices, COVID-19 Vaccine Safety Technical Subgroup. She's also, in her spare time, an Associate Chief Medical Officer at Stanford Children's Health, Professor of Pediatrics at Stanford University School of Medicine. So Dr. Lee, please begin. We look forward to your presentation.
Thank you so much. I really appreciate the opportunity to be a part of this panel. I will get started. My disclosures are that I serve on these groups, but I have no financial disclosures. As many of you know by now, the Advisory Committee on Immunization Practices is a federal advisory committee that advises the director of the CDC on recommendations for use of vaccines in the US civilian population. You'll see here at the table expertise and perspectives of 15 different members, including, I'll highlight that we do have a consumer's perspective represented. Importantly, we also have 8 ex officio members and 33 liaison members that's really cocoon us in terms of thinking about our recommendations. And I'll highlight here that 2 of my colleagues actually on the call from ACNM and BIO are both critical members of this liaison table, and also colleagues from ACOG, the American College of Obstetrics and Gynecology, as well as the American Nurses Association. As many of you know, vaccine development recommendations have been laid out in rapid form for COVID-19 vaccines over the past year. All vaccines go through phase 1, 2, and 3 clinical trials. From a safety perspective, there are data safety monitoring boards that are overseeing the safety of each of those trials to ensure that there are no imbalances in safety or adverse events that are occurring during the trial. After a phase 3 clinical trial is complete, typically that data is submitted to the FDA for a biologics licensing application. In this case, emergency use authorization given the public health emergency. And our colleagues on another federal advisory committee, VRBPAC, Vaccines and Related Biologics Products Advisory Committee, actually weigh in on the regulatory use of vaccines, and they advise the commissioner of the FDA. After FDA authorizes or licenses a vaccine for use, then that information comes over to the ACIP, and we then deliberate. And again, the Federal Advisory Committee, one of the key aspects of this is that we always deliberate in public in an open meeting, and we provide our recommendations to the director of the CDC. And a good example of this was yesterday when we did have an emergency meeting specifically to discuss a potential safety concern regarding the pause that was announced on April 13th regarding the J&J vaccine. In terms of the vaccines we have available for use in the US, there are 2 mRNA vaccines, Moderna and Pfizer-BioNTech, that are widely used. The Janssen vaccine is a non-replicating viral vector vaccine that has also been recommended for use in the US, is on a temporary pause. And AstraZeneca has been available in Europe, and we anticipate potentially may come to the US at some point, also under emergency use authorization. Just a really quick summary of the more recent vaccine effectiveness studies. So as many of you know, these vaccines have been found to be extremely efficacious in protecting individuals against COVID-19 disease. This is real world data from Israel showing that after a single dose, at least 46 to 57% of individuals are protected, much higher against hospitalizations or severe disease. But then after 2 doses, you can see 92 to 94% effective against protecting against documented infection or symptomatic illness, and outstanding protection against hospitalizations and death. In the US, there was a study that was conducted amongst healthcare personnel, first responders, and other essential workers, specifically looking at the effectiveness of the mRNA vaccines. And you'll see here even more optimistic information that suggests that after dose 1, the effectiveness may be as high as 80 to 82%. And that amongst those who are fully immunized, it's approximately 90 to 91%. So all of this is extremely reassuring. I know my colleagues will cover this particular study, but we also have noted that individuals who are pregnant, who develop COVID-19 infection, do have severe outcomes, including maternal outcomes, so death, ICU admission, and preterm birth, and infant outcomes, including stillbirth and NICU admission. And I'll defer to my colleagues to go over that data in more detail. I just wanted to speak to you briefly about vaccine safety. We have a subgroup called the Vaccine Safety Technical Subgroup that provides we meet weekly to basically review all of the data coming in from all of these vaccine safety surveillance systems. Early on, after vaccines were initially recommended for use in December and then in February for the Janssen vaccine, we have had all of these systems in place, and these were necessary for us to implement to ensure a robust post-authorization vaccine safety monitoring system for the US. So we have vSafe, which I'll tell you a little bit more about, VAERS, which is anyone in the US can report any potential adverse event, whether or not it's causally related into VAERS. And this is what serves as our early warning system. And CISA, which provides individual case consults for any cases where physicians need additional information. Or clinicians need additional information. In addition, we have these large linked databases that as more doses have been used across a wider range of the population, we are seeing more and more data from our colleagues at the Vaccine Safety Data Link and from our CMS colleagues through the FDA collaboration that they have. Our colleagues from the VA also have active surveillance up and running. And then we have some passive surveillance data coming in from DoD. But Genesis also is a nursing home based surveillance system that has actually been really helpful for us early on in the pandemic as well. Specifically regarding vSafe, I wanted to highlight this because many individuals ask, what can we do as vaccine recipients to contribute to vaccine safety? So the CDC set this up specifically for COVID-19 vaccines, and it's actually worked extremely well in that it's number one, easy to use. So I actually signed up for it myself after I got my vaccine to ensure that I understood how this system worked. It's a text messaging system with check-ins from CDC daily for the first week and weekly through 6 weeks, and then at quarterly intervals. And you complete a survey about any potential health impacts that you note related to vaccines. If there are any significant or serious adverse events, then the vSafe call center would actively follow up and actually report those cases into VAERS. And as you'll see, there were a robust number of individuals who chose to receive vaccines during their pregnancy And because of that, after a month or so, the CDC decided to set up a separate V-Safe pregnancy registry team, which actually has been incredibly helpful. This is just some brief data and overview on what's come in through V-Safe, specifically that local and systemic reactions are very common. We know this typically happens 1 to 2 days or 3 days after vaccination. They're very short-lived. This actually was really helpful because you could confirm that the data from the clinical trials holds up in that these individuals commonly had local reactions, but also systemic reactions you'll see here, and that it looks fairly similar between the mRNA vaccines. The other aspect of the data that came through and that was published in this MMWR was that the dose 2 was more reactogenic than dose 1. And again, we know that to be the case based on the clinical trial data that we saw. The V-Safe pregnancy registry, as I mentioned, was set up separately once they realized how many women were reporting in that were pregnant, and they specifically are interested in active outreach amongst those who are pregnant at the time of vaccination or even periconception. So I think 30 days before the last menstrual period. And they're following these women through during pregnancy and then after delivery until the infant is 3 months of age. And this is a great way to contribute to information about safety during pregnancy. To date, there have been 86,000 women who are pregnant who have chosen to get vaccinated and actually are contributing their information to V-Safe, which is really tremendous. I don't think anybody anticipated that this many pregnant women would choose to receive vaccines. I think one of the key aspects of our ACIP recommendations is we wanted to make sure that the vaccine was accessible to pregnant women, but that they have a conversation with their physicians or their midwives or their clinicians who are caring for them about the benefits and risks of vaccination. So this is a tremendous, a large number of women who actually chose to get vaccinated. And the V-Safe team is in process of now pulling these individuals over into a vaccine safety registry specifically. So there's up to 4,500 now as of April 12th, women who are actively enrolled in that registry, and they're continuing to work through that backlog that you see there. The early data coming from the V-Safe pregnancy registry, this compares individuals who are pregnant in the blue to those who are not pregnant. And you'll see that the reactogenicity looks very similar in terms of pain, swelling, redness, and itching after dose 1, dose 2, Pfizer, and then they only had enough information for dose 1 of Moderna at the time they pulled this information. The other thing to note is that from a systemic reactogenicity standpoint, it actually looked very similar as well. And they looked and queried about any pregnancy-related outcomes or infant outcomes and really saw no differences between what they anticipated in terms of pregnancy or infant outcomes in the data to date. And they are continuing to monitor this. And we actually meet, the VAST team meets monthly with our pregnancy experts. And just to end with this one-stop shop toolkit for pregnant people and new parents. So feel free to go to the CDC website for information. And I looked forward to my colleagues actually sharing their expertise and information about this going forward. Thank you very much.
Well, Dr. Lee, thank you so much. That was a great level set on some of the most important data so far. I'll turn it to our next panelist, Dr. Naima Joseph. She's going to talk about the COVID-19 disease and the vaccines in pregnancy with a little more detail. Dr. Joseph is a fellow at the Obstetrics and Gynecology Department at Emory University and a member of the Society for Maternal Fetal Medicine's COVID-19 Task Force. Dr. Joseph, to you.
All right, thank you so much. Again, it's my pleasure, my privilege to be able to present to this group today on basically the implications of COVID-19 disease as well as vaccination and pregnancy. Again, I have no disclosures, and the goal is really that you understand the literature on COVID-19 disease severity in pregnancy, as well as think about or understand the implications for kind of mitigation of these risks for pregnant women. When the disease was first declared a pandemic and we were first kind of understanding the implications of a respiratory viral illness in pregnancy, The first thing we considered was whether or not you could consider that pregnancy itself, due to changes in the immune system and due to changes in pregnancy physiology, made pregnant women at higher susceptibility to disease acquisition, such as been studied for HIV, where there's some thought that third trimester increases your risk for viral acquisition of HIV. Was this true for SARS-CoV-2 infection? And the answer was no, which is great because mitigation methods like masking, hand washing, et cetera, physical distancing, were equally important in pregnant women. However, we then started to look at whether or not the risk of disease in pregnancy was different compared to non-pregnant counterparts. The early data, which were case reports coming out of China, suggested that there was not an increased risk. But then there were small cohort studies that looked at the risk, especially in New York, in Philadelphia, that showed that there might be some signal, but these were kind of flawed by their lack of an appropriate control. And it wasn't really until we had two MMWRs that showed kind of longitudinal outcomes in a large cohort of women that were pregnant compared to non-pregnant women, and really showed that there was this risk for more severe disease in those who were pregnant compared to non-pregnant patients, even when you balanced out the comorbidities in each group. So this is kind of the key table that shows pregnant compared to non-pregnant women, their kind of relative risk for ICU admission, mechanical ventilation, ECMO, and death. And what they found was that pregnant women were 3 times more likely to need ICU admission, almost 3 times more likely to need to be intubated and mechanically ventilated, 2.4 times more likely to require ECMO, which is advanced kind of heart and lung support, and then 70% chance more likely to die as a result of the disease. Now, these were based on kind of large data. They're not very granular, meaning we don't have individual patient level data on how much of this was related to kind of obstetric complications, how much of disease management changed because of pregnancy. However, in understanding that the risks were higher for our pregnant patients, it became clear that the mitigation methods needed to be kind of more pronounced, and that vaccination would be really effective in this population as well. Outside of kind of the risk for pregnant women for disease, the next question was whether or not there was a chance for or risk for adverse obstetric outcomes. And again, there was a large kind of systematic review that kind of balanced out and kind of compared all the outcomes across lots of different studies, but the best studies were in those that provided cases and controls and compared asymptomatic to symptomatic disease. And what they found was that women who did have these had more severe disease or presentation were at higher risk for really bad pregnancy outcomes as well. So not only did moms with COVID have worse COVID, but then their pregnancy complications but they were also at higher risk of pregnancy complications. And that being the need for C-section, for having a preterm birth, and for stillbirth. The next question was really, what is the risk of the developing fetus and to the neonate? And the data so far are lacking as far as what the risk is to the developing fetus. We do know so far that the risk for early miscarriage, so first trimester before 12 weeks, doesn't seem to be increased, that the baby can acquire infection in utero. And this is the same for most infectious pathogens, like influenza is known to cross the placenta. So SARS-CoV-2 does appear to cross the placenta. We don't have a good denominator, meaning we don't really know how often this occurs and what the risk factors are for that. And so far from studies that have shown this, it doesn't seem like the infant infects as far as having a viral syndrome, like what's seen after CMV infection, where there's deafness and blindness. We're not seeing that. It does seem like the risk really has to do with prematurity and those babies being born early and dealing with kind of the prematurity related complications related to breathing and temperature and sugar control and things like that. But in the long term, so far, the cohort data we have do appear reassuring, but that again is the caveat that we only have data for about a year of these infants, and we don't have long-term data yet to see how these infants do at 3 years, 5 years, et cetera. And so really, there are lots of things in the pandemic prevention toolbox. What I'm going to focus today is really intervening before women and moms get the disease. Like I said before, masking, hand hygiene, testing, tracing, physical distancing, really important, and that's important to counsel and continue to counsel our patients about. How our vaccination is what is kind of the most debated right now. Right now, as we was mentioned, we have 3 vaccines available for use. The first 2 are the mRNA vaccine, the Pfizer and Moderna, and as was shared earlier, these are really effective against disease acquisition as well as developing severe disease, both in the clinical trials and in long-term data. These are mRNA vaccines. The side effects are really what's seen with almost all vaccines: local injection site pain, muscle aches, some fevers, etc. They're available to people 16 and 18 years of age, depending on the vaccine. And I think there's an EUA for Pfizer for 12 to 15-year-olds. And so far, there does seem to be good protection against the variants. And then the Johnson & Johnson or the Janssen vaccine, that efficacy is 72% overall and 86% against severe disease, so still an excellent vaccine. This uses an adenovirus carrier. The side effects appear to be the same, and also there's some protection against the variants. When we drill down how these work, mRNA vaccines basically work because in each individual cell, we have a nucleus that contains DNA, and that gets changed into RNA. mRNA is what proteins inside our body use to actually make more protein, enzymes, things that make our body work. And so the mRNA contained in the COVID vaccines contains mRNA against the SARS-CoV-2 spike protein, which is what triggers the body to start to develop and make antibodies that once the infection is seen naturally, the body can provide an adequate immune response and prevent infection and severe disease. They don't give you COVID. It doesn't affect our DNA because mRNA doesn't enter the cell nucleus. And this vaccine does get degraded pretty rapidly. Similarly, the adenovirus vaccine, the mRNA vaccine kind of has the mRNA encoded in this like lipid outer layer, whereas the adenovirus vaccine uses an adenovector virus to kind of get DNA into the cell, and then goes through the same mechanisms essentially of translating the DNA to RNA and then creating an immune response from there. Both these vaccines are really highly effective. I think Dr. Lee did a wonderful job of going through the US regulatory process. And so this is really just to emphasize that there are a lot of steps where a vaccine is made and approved and administered into the arm of a pregnant patient. The phase 1 and 2 trials really look at the safety and determine the dosing. The phase 3 trials really look at larger scale with a larger number of volunteers to establish that this vaccine works, that it's effective in preventing infection and disease. And then that data gets reviewed by the FDA and by the VRBPAC, as was mentioned, which is a separate independent committee that provides recommendations on its use. And even after the FDA approves for emergency use, the CDC has ACIP, which is another separate committee that really provides guidance on what populations. And so ACIP did provide language that was allowable for vaccination in pregnancy. And then organizations such as ACOG, SMFM, A1, et cetera, they are the organizations that say in this population, this is what you should be talking to about your patients. And these are the patients that you should really consider a vaccine for. We talked about safety concerns a little bit in that there's a difference between reactogenicity, which is basically this immune response to vaccine, which is what you want. It means that the vaccine is working, versus safety, which is medically important adverse events. And so far for the mRNA vaccines, the reactogenicity is about 2.1% and safety about 4%, really limited to anaphylaxis, musculoskeletal injury, and lymphadenopathy. And then specifically in pregnancy, because of the original trials, which did not intentionally include pregnant women, there's a lot of debate about the theoretical risk. People who have been involved in vaccine development and administration and pregnancy for most of their careers really felt like, and this led to SMFM's recommendations, that the vaccine should be offered to pregnant women because these theoretical risks, such as insertional mutagenesis, which is like the integration of the RNA, really could not happen. That these processes or that these vaccines would be degraded, that there was a short half-life, that there was a clean manufacturing process, and all the data on vaccination has so far been really safe. And then we're able to have real world data about mRNA vaccines. First, Pfizer and Moderna released their DART studies, which is our preclinical studies, animal studies, which is where a lot of our initial data on risk in pregnancy come from. And those data were reassuring: no increased risk of birth defects in animal models. There were persons that were inadvertently enrolled into the trials that were pregnant, no increased risk there. And then, as was shared, we did have data from VSafe that essentially showed that the pregnancy outcomes were really not worse in vaccinated individuals compared to non-vaccinated or the background rates. So VSafe is so important because this is how we're able to get the real world data, as even though we're all advocating for the pregnancy or pregnant patients not be excluded from trials. Until then, these are the data that provide us the reassurance that this vaccine is safe for use in pregnancy. Specifically, we're not seeing increased risk of miscarriage or stillbirth, pregnancy complications like diabetes, preeclampsia, growth restriction, or neonatal complications like preterm birth or congenital anomalies. And this is all from the VSafe data. So the mRNA vaccines thus far are showing to have really no adverse risk to pregnancy. The J&J vaccine, as was alluded to earlier, is currently on pause due to 6 cases of the cerebral venous sinus thrombosis and thrombocytopenia, which most of you may remember, this was initially reported with the AstraZeneca adenoviral vaccine as well. In the US, these occurred in women age 18 to 48 within 6 to 13 days of vaccine. It is concerning that they were of reproductive age, but again, it's a very small number out of the 6.85 million doses that were administered, and we don't have any information on to what the reproductive status of these women were. Before this, though, there were good data about AD26 vector COVID vaccines in pregnancy. There were 8 people that were in the DART studies. I'm sorry, there were 8 people that were in the clinical trials from Johnson & Johnson, and their DART studies were also reassuring. And then this was a vaccine technology that had been used for Ebola in HIV. And from that data, there was acceptable safety and reactogenicity without really pregnancy-related safety concerns involved. And so really kind of talking to our patients about vaccines and pregnancy, it's really balancing the risk and benefit. And so when we talk to our patients, it's about what is your risk for COVID-19? One, what is the risk in your community that you would get the infection? And what is your personal risk that you would have really severe disease? Knowing that severe disease impacts your mortality, impacts your ICU admission or disease severity. And then also, while also increases your risk for an adverse pregnancy outcome. And then the trade-off between the vaccine benefits and uncertainty. Again, the real uncertainty is that vaccinated women were not included in the clinical trials, but the real world data so far looks reassuring. And the side effects are low and the efficacy is quite high in terms of prevention of severe disease and infection. I think that's it for my slides. This is my contact information. I'm always happy to, obviously I'll stick around to answer questions, but also happy for you to contact me this way as well.
Thank you so much, Dr. Joseph. Very, very helpful. So I know that in addition to concerns about pregnancy, there are also discussions and concerns about fertility and future fertility. And so our next presenter, Carol Hayes, will help us walk through fact versus fiction on this issue. Ms. Hayes is a nurse midwife with 30 years of clinical experience in women's health, immunizations, infectious diseases, sexually transmitted infections, and HIV. She serves as an immunization advisor to the American College of Nurse Midwives and is an ACNM liaison to the CDC's Advisory Committee on Immunization Practices. Ms. Hayes, please.
Hello, everyone. I have a very brief presentation here. We're going to have lots of time for questions. The chat box already has a question in it, so I'm glad to see that. So the most important thing I think that we have to work on is the misinformation that so many people have about vaccines. And, you know, social media has really changed the way they have to talk to patients, and false news travels so quickly on social media. And it takes a lot more time to verify science. And I think we have to work extra hard in these times to make sure that we quell misinformation. And when the COVID vaccine first came out, one of the things I heard was that most of the nurses on the floor were like, I'm not getting it because it's going to affect my fertility. And so we had to really, really work hard. And I think we're seeing a lot of vaccine hesitancy. And one of the things that I learned last year is that the anti-vaccine groups are actually incredibly well funded. They have millionaires that are helping to produce videos about how dangerous vaccines are. And so we have to work really hard to make sure that we're keeping those folks quiet and the science loud. So given the risks and of the disease that has just been presented, the World Health Organization, the American College of Obstetricians and Gynecologists, and the Society for Maternal Fetal Medicine created a task force that basically said we have to keep up with the science, and that vaccination in pregnant women or women who are attempting to become pregnant is recommended. And the CDC and the FDA, we've heard a wonderful presentation from both of the previous speakers working on our safety data, and our safety system works really well. When we have anything that's alarming, the safety systems that are through the CDC, through the FDA, are monitored so closely. And we have such great information about the safety of these vaccines. And we have what happened yesterday, an emergency meeting specifically addressing the safety of a vaccine. We don't have any data yet on the safety of the J&J vaccine in pregnancy. We're hoping to have that soon. So the most important thing to understand about the two vaccines that are currently available to everyone while the J&J is on pause is the mRNA. Everybody thinks, oh my gosh, this is scary. It's a brand new system. How do they know it's safe? And we have to remember that the mRNA system of making a vaccine, they've been working on this for 20 to 30 years. This is the first time we've used it in humans, but it's been around for a really long time. When this mRNA vaccine enters your body, it comes in, it says to the immune system, come on, recognize this pathogen, start to have an immune response. And when it initiates this immune response, it does not interact with our DNA that's in our cells. It does not enter the nucleus of our cell. And it then degrades very, very quickly, and it is gone. So we have so much about this that people are so afraid that this mRNA is going to affect their fertility. And there is no data to suggest that it can in any way affect our fertility. You've had the two previous presenters have also talked about V-Safe. It is such an incredible, simple way to allow us to contribute more data. And when I give the vaccine to people, I say, please help us get more data. Please join with this system. It's voluntary. You can opt out at any time. And I have to say, the thing that's frustrating to me is how many people in their 80s and 90s that I've been vaccinating that don't have a smartphone, and so they can't enroll. And I feel like we're missing the the truly old geriatric population in V-Safe. But we're trying to get as many people as we can. And the data to date shows these safety profiles are incredibly reassuring in the general population and specifically in pregnant women. And so that's my brief presentation, and I will stop sharing and move on to the next person.
Jose, thank you so much. I'm gonna make sure we come back to the question that was answered in the chat, because I want people to hear the answer as well, but we'll also keep the written answer. Thank you both, Dr. Joseph and Dr. Lee, for answering that. We'll come back to it. So our final presenter is Melody Butler. Melody is going to share her personal experience with vaccine hesitancy and how it inspired her to advocacy in this space. Ms. Butler is a mother of 4 and a registered nurse. She's the founder and executive director of the organization called Nurses Who Vaccinate. She served as a member of the National Vaccine Advisory Committee, or NVAC, within HHS from February of 2017 to 2021. And she's also been an advisor to different national public health organizations. And I know Melody's actually at work, but she's going to come to us from her phone. And Melody, I want to turn it over to you.
Well, I am very honored to be sharing my lunch break with you fine, lovely colleagues. So thank you very much for all the great presentations. And I can't wait to bring back this information to my fellow patients and colleagues. So I'm here today to share my personal story of vaccine hesitancy and how it can relate to the presentations we've heard today. Back in 2009, I was pregnant with one of my children, and it was during the H1N1 outbreak. So during this time, while living in New York, the cases took on a pretty significant surge, and New York State decided to make it mandatory that all healthcare workers were to receive this new H1N1 flu vaccine in order to maintain their job. So when I took the opportunity, I went online to look up what is the internet saying about this new vaccine. And some of the stories I had come across were very alarming and quite scary. And they actually led me to make the decision that I was not going to get the vaccine, and I was prepared to be fired if that was going to be the case. And here I was, a college-educated registered nurse working in pediatrics. I thought I knew what I knew, and when I brought this information forward to my clinical nurse educator, she took the time to sit down with me and she asked me, well, what are you basing your decision on? So I showed her the websites. And as I was bringing them up, she was very calmly and professionally and with humor able to explain to me why some of these very deceiving websites were not at all evidence-based. While they appeared to be a healthcare organization, when we dug down deep, we found out that many of them did not have the proper credentials. They didn't have the background in infectious disease, vaccinology, even in public health. And so after we debunked many of the myths and rumors we were coming across, she took the time to show me what the CDC was actively saying, the studies that had been released on the H1N1 vaccine, that it wasn't just something randomly pulled out of a vial somewhere and being administered, but it was very heavily vetted and had been investigated, and the technology had been there. And just more reassuring data that I needed to see that I just wasn't having access to, or just wasn't showing up in my social media feeds at the time. So after I realized that I had been scammed by these websites, I had made the decision to go ahead and get the vaccine. A little bit later on in the flu season, we ended up having an issue with distribution and we did not have enough doses. So New York ended up recalling their mandate. And I had a fellow pregnant friend who lived elsewhere in the state who was desperately trying to get a vaccine. By the time she was able to secure her appointment for the vaccine, she unfortunately ended up contracting H1N1 and wound up in the hospital. She was pregnant with twins, but unfortunately, due to the complications of H1N1, she ended up losing one of her twins during this time. So to see that I could have willingly placed myself in a situation that could have put myself and my child at harm was such an eye-opening, disheartening experience, because here I was, I took a lot of, pride in my education and, staying up to date with everything that we do here as nurses. And I could have, made a very misinformed decision based on what I was seeing. So it always stuck with me that this information can really lead to very powerful, very dangerous decisions down the road. So knowing what I knew, a couple months later, I was online once again, and I was coming across social media pages featuring nurses who were once again promoting misinformation. So I took it upon myself to do what my clinical educator had done for me, and I took the opportunity to introduce myself, and I was willing to share with them the wonderful world of vaccines and public health and how important they are and all the safety information. And I discovered that not everyone is going to be receptive or willing to admit that what they're sharing is wrong. And it led to very interesting conversations that down the road led me to found Nurses Who Vaccinate. And Nurses Who Vaccinate, what we are a community where nurses can come together to ask questions. It's a safe place for information, collaborate to plan events, debunk the latest in, trending disinformation on the internet. And we're present on all the social media backgrounds. So what we do is, we really try to incorporate a couple of key ideas when we're educating and whatnot. And we have developed vaccine hesitancy steps and tips over the years. And, as nurses, as APPs and physicians, we can help build confidence among colleagues who might be vaccine hesitant to receive a vaccine. So it's not always the patients that we're talking to, but our fellow colleagues. And that's what we really work hard to instill, is this confidence among our colleagues. And within the health sector, in many countries, women, they make up over 75% of the healthcare workforce. So these, concerns that we're addressing here with the fertility and the pregnancy issues, this is such a very hot topic in the healthcare industry. And it's so important that we are confident when we're spreading this information. But it starts with listening. Just like my clinical educator did for me, we want to make sure that we're not lecturing, but, when we don't want to assume what our patients or our colleagues' concerns are, we have to make sure to listen and letting people know it's okay to have questions and that having concerns is legitimate. Giving our friends, our colleagues, patients a safe place to have this conversation is essential. Of course, we want to address misinformation and misconceptions. But when we're doing that, we want to remind people of the vaccine safety and all the data that's been behind it. So when I'm educating about the current Pfizer and Moderna trials, vaccines available, when I speak about the trials, I let my colleagues know that, they were 10,000 Hispanic people tested, and the vaccines were shown to be safe in all ethnicities. And many of the patients and my colleagues, they don't know this. They're not aware of the fine data, the points. So when we're sharing these talking points with them, one is going to register with them, and then they can bring it back to their patients as well. And sharing personal stories, I am very open with my experience, and I let my friends, my colleagues know that I had been taken for a ride. I had been scammed, and these websites and these social media profiles, they can be very convincing. Sometimes someone's grandmother, they mean well when they're sharing a post or an email, but it's so important that we really, stop, pause, research what we're going to reshare and repost, make sure it's accurate and up to date. And sharing my personal story really helps others to feel more comfortable and admit maybe I have to take a second look at this, or it's okay to be wrong and then admit that and move on. And I cannot stress how important it is to be patient. It's going to take several conversations before someone may be ready to be vaccinated. For me personally, it was not a one-time deal with my clinical nurse educator. It was over several shifts that she took the opportunity to touch in with me, touch base with me, follow up. She wanted to make sure that I had read the information she had sent me, and if I had questions, she really cared, and I felt that. And the rapport I had with her before, of course, helped. But even so, with this whole event, it really strengthened our relationship, my trust in her. So it really was, many different factors played into this, and it's so important that we remember to be patient. And once again, it's okay to admit to others that maybe you're not the right person to educate them. I mean, there's been some times I kept hitting a wall with someone, and I was like, you know what? I'm going to refer you to my colleague. They're better equipped in this particular area that you're having all these fine questions in, and maybe they'll have a better ability to talk to you and maybe speak a different language that a different pathway of getting the message across, and that's worked. Sometimes it's okay to take a step back and let someone else take over the reins of educating. Sometimes, just like with our kids, sometimes they have a great teacher, but, they need that extra tutor on the side to really get the points across. And we can use that. We can use our referrals and tutors within our own workplace and colleagues. So, with any of the takeaways you have here, just remember that Nurses Vaccinate, we're an organization that's here to help not just nurses, but, our nursing nurse practitioners, our physician assistants, our physicians. We're a teamwork. It's collaborative. We work together, and this can be replicated on many different ways and models. But we take pride in all the work we've done. You can see some of the pictures that we've had in here of our members, of course, throughout 3 years when we're allowed to meet in person without mask. And all the work we've done and all the collaborations we've had. Very briefly in my introduction, Phyllis had put very nicely stated, we partner with a lot of different organizations. So we partner with Shot at Life, which is a United Nations campaign. So our nurses find ways to advocate for children vaccines on a global level. We partner with Voices for Vaccines when we work with parents to help parents be vocal advocates in the community. And we partner and work with Vaccinate Your Family in regards to making sure that domestic issues are being addressed and people are confident in the information they're receiving. We have other partnerships right now with ANA, working, we're very close with NFID. We work really close to share the information that's out there, because nurses, when they're at the bedside, they're not always going to get their emails. They're not going to check the webinars. They may get their emails be filling up with all these wonderful recordings, but it's going to be us taking that extra step to bring, the fine points to them and debunking all this misinformation. So I just want to thank everyone here for taking the time to provide this webinar, which is so important, which I can't wait to bring back to my colleagues who work in maternal medicine and mother-baby. This is what we need to be doing. So thank you.
Fantastic, Melody. Thank you. A great ending presentation to the overall discussion. So people have been answering questions in the chat, which is in the Q&A section. I wanted to see which ones we should pull out. I think the one I'd like to have read out, maybe there was a question about how soon should we vaccinate? It sounds like, someone suggested ASAP, but what about later in the trimester, earlier in the trimester? Can we just have a couple of people, I know we typed an answer, but just give a little bit of a verbal answer on that question.
And just a housekeeping issue.
Yes,
Only the panelists can see the questions and answers.
okay. that's
The
what I was
attendees
wondering.
cannot. So
That's
we
what I
need to,
thought.
yeah, we need to
We
read
need
the
to go through them.
question and
Yes,
read the
exactly.
answer.
So
Yeah.
the question was, I picked this one first. Thank you, Carol. I was worried about that. Is there any advice on the timing of vaccination? We assume right away, but is it later part of the trimester? When, what information on impact on pregnancy and vaccine efficacy will we have? And I see Dr. Lee, you typed an answer, so probably should answer this one. And you're
Sure,
on.
thank you. I was just trying to scan the data really quickly. So it looks like, at least in the V-Safe pregnancy data, about half the women, or almost half, were in their second trimester, and a quarter were in their first trimester, and a quarter were in their third trimester. What we can see, at least of the data that's coming in from the CDC national data, is that the vast majority of cases of COVID-19 disease have been reported in women in their third trimester, then second, then first. In terms of the timing, I mean, I'm going to defer to Dr. Joseph Hayes Butler, just in terms of the conversations that you have with your patients, because I think that's really the most important thing, is to have a conversation. I think some individuals are able to mitigate risk in other ways. And others really, are on the front line. They're essential workers. They need to, either healthcare workers, they need to be sort of in that setting, and the exposure is ongoing.
Yeah, that's exactly right, Dr. Lee. As far as, there's a lot of debate within the societies as far as when to recommend vaccination, given that we don't have data about trimester-specific risks. There are only 2 vaccines that are currently recommended in pregnancy, which is influenza, as well as the DTaP, which is diphtheria, tetanus, and pertussis. And the way we kind of think about it is the DTaP, the risk to a pregnant person of acquiring that infection is really low. And really the benefit is neonatal immunity in terms of the maternal immune response does lead to antibody that transfers across the placenta and really provides really good neonatal immunity, which as you may or may not know, to the audience, that most kids don't develop a really strong immune response until about 6 months to a year, and that a lot of their immunity is really achieved through breastfeeding and through what is crossed in the placenta. Conversely, influenza, you're a pregnant woman at risk for that throughout their pregnancy. And so that is really offered independent of trimester because there's this risk to mom from developing that infection. And we know that influenza in pregnancy is even more harmful and associated with worse maternal disease and even COVID. And so we initially in our recommendation said that as soon as it's available to you, you should not wait, you should just get the vaccine. And we have not changed from that because the maternal risks are so high and it's really unclear the efficiency of transport across the placenta and the neonatal protection. There's one study so far now that shows kind of lower than you'd expect efficiency of transfer through antibodies that are delivered from the placenta, but that breastfeeding still provides a really good way for neonates to get immunity, and that persists independent of trimester of infection. So far, moms are at risk throughout pregnancy. Most of the data have come from second and third trimester. It's not sure if that's kind of a bias in the reporting or if that's actually when the disease risk is the highest. Probably it's related to the disease risk is the highest at that point in pregnancy. But given the ongoing risk that moms should be protected whenever they have access to the vaccine, they should get vaccinated, and then know from a neonatal benefit that there's still some protection confirmed a little bit through the placenta, but also through breastfeeding.
There was a question about some data coming out of Ireland on the B117 mutation, which everyone should know is UK mutation, being associated with cases of placentitis or stillbirth. Have we seen anything like this in the United States?
Yeah, I wanted to say that, the placentitis and villositis has been reported since the first wave of the infection. So there were case reports back in March and April that did show that there was placental changes following COVID vaccine that were associated with conditions that we know are associated with higher risk of stillbirth, meaning that the placenta changes were similar to what you see in diseases like preeclampsia or other maternal kind of cardiovascular conditions. And so the finding of villositis and placentitis is not new. Stillbirth, there was a systematic review that showed higher risk, but when you looked at the studies individually, they didn't really have good controls. And so whether or not, definitively, whether or not stillbirth is associated, stillbirth is such a rare outcome that it's really hard to say definitively. We need like lots of numbers and long-term data for sure to know for sure, but there may be a risk. We don't really quite know that yet. But the B117 variant, I would not say that the finding of a placental change is new, because we've known that, and there are data that show that in virtually all pathogens cross the placenta. But I do know that, and we all know that B117 is highly kind of infectious, and that kind of tells us that vaccination is even more important, given that the vaccines do confer some immunity against the variant.
Wonderful. Great question about the use of monoclonal antibodies in pregnant women. Is that warranted, particularly if they've had close contact to someone who's positive for COVID? And I saw Dr. Lee and Dr. Joseph, you both answered this
I
one.
did my best to answer it, but again, I'll defer to my colleagues on the phone. I just know from an infectious disease standpoint that we only recommend it for use in individuals who have confirmed infection, mild outpatient disease. I know that there are other trials that are ongoing, both to lower the age and also to look in immunocompromised populations, but that data is forthcoming, and I don't believe there's any indication for prophylaxis. And the biggest recommendation I would suggest is just to continue to do what I call is bundle up. Just bundle up all your measures and do the best that you can to adhere to them, because vaccines are an incredibly effective way to achieve that protection. But masking, social distancing, avoiding indoor gatherings, large crowds, that kind of a thing, I think are also helpful. So as much as you can do, I believe in risk mitigation all throughout.
And there's another question actually from of one of the people who's pregnant. She's in her third trimester, and she wanted to know how to weigh these issues with what it might do, how it might affect the infant themselves. And her biggest question is, why is it okay for pregnant women to get it, knowing now that there have been some cases where antibodies have been detected in newborns? So how should she be thinking about this with newborn antibodies, but not necessarily young children antibodies? How do you think about the impact on the child? And Dr. Joseph, this might be a good one for you as you look at that intersection between mother and child in your daily life. Sorry to put you on the spot.
I'll give the perinatal perspective, which is, so the antibodies specifically are those targeting the SARS-CoV-2 spike protein. So those do get transferred across the placenta. Like I said, there's one study, 130 patients. We have an ongoing study now that we're going to publish soon, but that there is some efficiency of antibody transfer. It's not as high as you will see after influenza and after pertussis and tetanus. So not as high as what we know that the placenta can do, but still I understand that. And we know that, neonates are not at risk for COVID disease, and that, that an MWR did publish pediatric hospitalizations that showed a good number of those hospitalized were children that were under a year, and that antibodies kind of get transferred either through the placenta, but also through breastfeeding. And so really thinking about vaccination, there's some protection from vaccination during pregnancy. A lot of it is also through breastfeeding. It's probably where the majority of it comes from, as far as we know now, and that there is safety in the third trimester.
Great question here. What data exists now to show that these vaccines don't affect fertility specifically? Our studies plan to look at rates of pregnancy in vaccinated versus unvaccinated, and it would be good to have more information to share with patients at the present time.
So, we don't really have hard data yet on fertility, and I'm not sure that we will be able to, because so oftentimes, 50 to 60% of pregnancies in the United States are unintended. So enrolling people, attempting to enroll non-pregnant people to find out what their fertility rate is after vaccination, that would be a very difficult study. But from a theoretical standpoint, the way that vaccines work is it's really physically impossible for them to impact the endocrine system. So they don't, vaccines work in the immune system and they don't affect the endocrine system in any way. So I don't think we'll ever have hard data on it, but there's no indication from the scientific standpoint that it affects either men or women in their fertility.
Anyone want to add to that one? I think that's an important scientific distinction you're making, Carol. That's really helpful. Another person says she has a close friend who's pregnant, not an essential worker. She's working from home, 6 months pregnant. She's getting mixed information, and her doctors even her physicians are giving conflicting information. How can she make the best decision based on that, besides as this woman says, besides prayer, which is of course important, but how can she make a decision and get the right information for her?
So I want to just remind that the American College of Obstetricians Gynecologists, the Society for Maternal Fetal Medicine, and the American College of Nurse Midwives all have very strong statements about the safety of vaccines in pregnancy. And we all have websites with vast amounts of information. So I would highly recommend, for instance, on our website, we have not only patient education materials, we have some really wonderful, as a matter of fact, I'm just going to brag for a second. And I'm going to share my screen because I want everyone to see our really cool Supermom campaign. And so we have posters, we have patient education brochures. We don't have one yet on COVID because we don't have enough science, but like we have one on an overview on vaccines in women. And on each one of our brochures, we have, oh Lord, can't open up a PDF, sorry. We have we have all this great material. And one of the ones I want to point out is we have a brochure we just recently created that's called Vaccinate Confidently, that's meant for healthcare providers to be able to use on how you have a conversation to strongly recommend a vaccine, and the CDC website. So the CDC website has a specific section on vaccinating in pregnancy. They have a specific section on the COVID vaccine in pregnancy. So I highly recommend that we direct all of the women that we encounter to reputable places like professional organizations and the CDC. That's where she's going to get her questions answered about what to do about a vaccine. And ACNM has our social media about vaccines is very strong. So you can recommend that they follow ACNM on Facebook and Twitter. And ACOG is the same way. We have a very strong social media presence.
So what we'll do, this particular session will be posted in the BIOS COVIDvaccinefacts.org website. It has questions and answers to a lot of different things. We'll have the webinar posted there, but in addition, we have a page that links you to different resource pages. We will make sure to put all these organizations links to their websites in the resource page. So you can also find Nurses Who Vaccinate and all the different societies that have been presenting today, and link to the fantastic resources that you've seen. But we want to make sure that people are able to both get the information they need, but also those of you that are advising others have access to tools that you can use to educate other nurses or all of your patients as you talk to them about the COVID vaccine. So we'll make sure to update our website with links that were included here. We'll have the webinar posted as well. I mean, we're out of time. We could obviously answer more questions. These questions were fantastic. Thank you all so much. Thanks so much to our panelists for your commitment to this space, but also your fantastic answers. And we look forward to talking with many of you again really soon. Please use the webinar and our websites and all the websites of the panelists themselves. Take care and stay safe. Wonderful.